a question that always comes up is in clinical trials, we are always given very specific criteria to stop treatment. But in clinical practice, we see patients that have disease progression that in a clinical trial might be change in therapy, but they are tolerating therapy well, they are not developing new sites of disease. And so how do you make the decision about when to switch from first-line therapy? What are those criteria that you think matter for our practicing colleagues?
Yeah, it's an important question. So I think one of the shortcomings of how we make these decisions on clinical trials is that we are bound to whatever algorithms are set forth in the protocol, and oftentimes actually have to take patients off of treatment, although the patient and the treating investigator may not want to. So in clinical practice, we have a lot more freedom to do whatever we choose. And I think there's a couple of paradigms that everyone would agree upon that determine an agent should be switched. One of them certainly is the development of newly symptomatic disease. So if patients develop new symptoms or worsening symptoms in the setting of disease progression, be it small in radiographic extent or large, that to me is an indication to change study treatment. And you know, one can also integrate the tolerance of therapy. So it's keeping that balance of having a patient stay on treatment as long as we feel that their quality of life is preserved and the disease is controlled radiographically. I personally do not do RECIST assessments outside of clinical trials. Few colleagues do, but I don't do the millimeter measurements, sum score analyses for my patients that I treat outside of a trial. I look for a change in pace of the growth. If I keep patients on a treatment despite of slow growth, I watch very closely whether the pace of that increase goes up with future scans. I look for the emergence of newly metastatic disease in organs that were not previously involved. That to me is an indication to switch clearly. And like I said before, new symptoms related to the disease progression here. Some of this differs now for which type of agents you use. So with tyrosine kinase inhibitor therapy, one might approach that very differently than with an immunotherapy, where we think about interpreting radiographics and the dynamics of treatment response differently.
Michael, you have some thoughts?
Yeah. I think things have changed a little bit with regard to when to switch in the first line with now 10 different drugs approved. And if someone has disease that's growing, or if they're not tolerating the first line treatment and you've been forced to lower the dose, and then because you've lowered the dose, the disease is no longer responding, I think there's a quicker sense to try to switch to a second-line therapy because we, as I said before, we have better second-line treatments than the first-line treatments. And so moving to nivolumab as an approved second-line therapy after someone who's clearly not going to get a major response anymore to a VEGF inhibitor is something that I think a lot of us do. And we also know that patients who have responded to a VEGF inhibitor and then have started to become resistant, if you give them a break from that, they can become sensitive again. So giving them a break may also be useful if they don't end up responding to the immune therapy. So when we used to have only 1 or 2 approved drugs, you wanted to give it for as long as possible. But now that there are other drugs, I think you individualize that decision, and I think people are quicker to look at second-line therapies than they might have before.
So to kind of close our conversation, tie around, first-line approaches before we talk about what decisions we have about going to second-line, are there any special situations? I mean, we talk about metastectomies. We obviously are using radiation therapy appropriately. I mean, what's happening to our patients with brain disease is dramatically different than it was decades ago because of the availability of the gamma knife. We know that some of the drugs that we give actually can control some of the central nervous system symptoms. And also there's still this drug temsirolimus that's out there that has been approved in the frontline setting that many of us would think about not using absent some next generation sequencing abnormality in the PI3K mTOR pathway. Any special situations that our colleagues need to know about that you think about when you're treating in the frontline setting?
You know, when I think about it in the frontline setting, I look at see the burden of disease. I still think there's a role for surgical consolidation. That's something that the Mayo surgeons have always been very aggressive about. And often you may have a patient with oligometastatic disease, and if you can achieve control in oligometastatic disease, often I talk to the patients about a potential for surgical consolidation. There are also certain subsets of patients that seem to have more of an indolent disease, such as patients with pancreatic metastases. It's rare for a lot of tumors to go to the pancreas, but kidney cancer is one of those. And that particular patient population seems to have a little bit more of an indolent disease than patients without pancreatic metastases.
Although I must tell you, in my own practice, having treated kidney cancer patients now, like Michael, for decades, it's only as the patient survives longer that you see the metastatic disease in the pancreas. So our successes have led to some unusual new presentations.